Okay, I am Amy Mooney. I'm an occupational therapist, and I am in Chicago. So I wish you greetings from Illinois. I am the caregiver, the full-time caregiver of a loved one with ME. So I would like to give you a little perspective, on how I kind of came about this field. It was not something that I was trained on originally, and it was something that I learned through a lot of literally blood, sweat, and tears. So I felt that the education that occupational therapists and physical therapists are receiving is an amazing education in general for people that have understood illnesses, but when it comes to ME and some of the comorbid conditions that are the kind of the unlucky baggage that so many people experience, therapists aren't prepared for this. And I spent a lot of time trying to figure out what it was about my profession, which I loved very dearly, that was not helping my loved one. And I spent a lot of time, and I still do, in patient groups and caregiver support groups, and trying to figure out what it is, how to help individuals that have been misappropriately misappropriately cared for in trying to receive therapy. So as an OT, let me see if I can change this. This is not wanting to advance, so hold on one second. I might have to, there we go. So typically the goals of OT is for helping your patients participate in meaningful and purposeful activities. Occupation is meaningful when it allows individuals to really fulfill the goal that is personally or culturally important. And it is purposeful when it is determined by the individual, that is unique and interest that has the environmental context of the individual at heart. This is not something that is cookie cutter at all, and it needs to be really designed for the individual. So that is what I really value for occupational therapy, is that we know our clients, we know our patients from a holistic view. And I think that understanding the individual in the context of play and work and leisure is part of the goals for all of our clients. But when traditional OT and PT looks at what are the things that you see, what comes into your clinic, what are the observable things that you can measure, such as increasing strength or range of motion, what the endurance, what their coping skills and their strategies are, and what are we going to do to restore health, and what are we going to do to restore functioning for an individual with what we can see in our clinic or what they are reporting. But we often disregard or do not see what is hidden below the surface, and that is the crash, that is PEM. And patients will report it, but if we don't see it, it's really hard to put our finger on how to treat it. How do you treat a crash that you have not seen? And it's extremely frustrating for patients and caregivers to say, yes, they can do that in the clinic. Yes, you see it in the classroom setting. You can see that the child is sitting at their desk and they are listening to the teacher, but you don't see what they look like when they come home. They are a disaster. They are collapsing. They are crying. They have so much pain. And how do you find that balance between what they're able to perform and do in public, and then how to support them for the crash? And I, over years, I struggled with trying to figure out, is it me not describing it for my loved one? Is it my loved one not knowing the right words? And I finally came to the conclusion that it needed to be flipped. The iceberg actually needed to be flipped. And so what we need to focus on is not what is observable and what is measurable in a clinic, but what is the reverse of it. We need to look at what the crash is like and start identifying the core of the crash, and then start working from the base up and supporting the individual, such as managing their symptoms, managing the activity. What is it that the activity is actually doing to make the symptoms worse? Or what is the quality of the symptoms? What is the nature, such as, is it physical or is it cognitive? Which type of or activity makes the actual symptom and the crash worse? And then also the rest. Clinicians typically don't look at rest. What does rest look like for an individual that is trying to recover or recuperate from their exertion? Because many times patients will lay on the couch and still be on their phones and scrolling and thinking like, I just spent 2 hours resting and I don't feel well. But that actually is still exerting. And so I wanted to look at what type of rest they are doing to restore their autonomy, giving them meaning. Sometimes activities have more value in it than we really give it credit for. Patients don't want to necessarily spend a lot of time in the kitchen. They just need the food to be able to get them nutrition and beyond, with be next on their activity list of meaningful and purposeful activities. Those things together will lead to improved quality of life. And that's the goal, is to wherever the patient is at, is to improve their quality. They might not be back, and they will not be back to where they were pre-illness, but if we can just make their symptoms more predictable and give them more control, they have more quality in their day-to-day living. So like the other presenters have talked about, the first thing you need to do is screen for PEM. You need to identify who has it and who does not. And those, like Michelle and Natalie mentioned, those are just simple questions of asking what happens when you engage in normal, previously tolerated physical, cognitive, sensory, emotional activity, and looking at what their recovery is like. How long does it take for you to recover? And this is a big piece that I think that is missing from a lot of evaluations, is how long does it take for you to feel the initial symptom response, and then how long does it take for the crash to actually hit? That we know is a delayed response. Crash often does not happen for a day or 2 or 3 days later, and patients have already moved on. They've forgotten what the trigger may have been, and they've maybe moved on, and so they are layering crash upon crash. And we need to separate those things and tell them and help them identify that typically a crash will not happen for 24 hours, for example. So do not plan your next activity for maybe, for 36 or 48 hours. So we want to give them identifications, and I'll go into a little bit of that soon. The first piece is making order out of chaos. All of these symptoms are just a big kind of a ball of yarn that is all knotted together. And it's really overwhelming for patients to feel all of these things, and it's happening to them without explanation. But if we can give them a little bit of order, is it mast cell that is really active and needing to be managed with medication? And can we identify some of these symptoms that your doctor can start giving you strategies, giving you pharmaceutical interventions that may start addressing some of these responses. Are you getting, you know, a lot of your cardiovascular, your POTS, your blood is pooling at your extremities? If we can start identifying some of these types of symptoms, we cannot necessarily take away all of those symptoms, but we can at least start ordering them and finding out what types of symptoms are presenting at different times. And if we can intervene to give a little bit of relief for some of these otherwise unclear and chaotic experiences. And this is where I focus a lot of my time with patients, is by looking at how symptoms present over time. What's the time course? Workwell has also looked at this piece and has some nice handouts on the time course of symptoms. But I have decided that sometimes just looking at what the immediate response is and then what the delayed response is gives us a good start for kind of helping build the structure, the scaffolding for pacing. So looking at what the immediate symptoms are, asking your patients, when you do a physical activity, what are the immediate things that tell you to start slowing down? What's the stop sign? When you do physical activity, one of my patients had said that they feel a lot of POTS symptoms. They have their heart racing, they have their blood pressure changing, they get pooling, they get lightheaded. But when they do cognitive exertion, they immediately feel, and this is what my patient described, a squirrel rattling around in her brain. She just feels that it is just this buzzing, and it is kind of this fog, but she just said it's wired but tired. So she was describing it the best way she could. And you can tell that these are her immediate symptoms for two different types of exertion. Physical exertion versus cognitive have totally different symptom presentations. For emotional, when somebody feels that they've been in a social setting a little bit too long, they may feel like they're not following the conversation. They might feel like the lights are too bright. Those are all things that I want patients to start noticing, because that's your warning light. That's like your engine light coming on saying, you need to start paying attention to your symptoms, because this is how you usually present. And when you go beyond, you will feel more severe. So I often ask my patients, when you first start identifying those symptoms, the next piece is to ask, can I give it another minute or two, or do I need to stop now? And that's where putting the priority on the activity. How important is this task or this activity? Are you in the middle of traffic and you cannot stop where you are? Or can you get to some place where you can pull over and take a break in a parking lot and maybe rest for a half an hour? So the immediate symptoms versus the delayed symptoms, which are very important in understanding how long it takes for that delayed response to happen. One of my patients has said that it is not present for 2 days. So she knows that when she does something after she exerts, she comes home, or she finishes what she had done. She then waits 2 days for her delayed response, and she knows it's coming, but she has to take that time to be at home, rest, reclined, ice packs on her head, eye patch or the noise canceling headphones and eye masks nearby, because she knows that crash will take 2 days. Before we started working together, she was already on to her next activity. And so that crash would just accumulate. And now that we've identified it for her, she can wait for that crash, and it's not as severe, but she knows it's coming before she plans the next event. And so scheduling and understanding what your immediate symptoms and your delayed symptoms are, how they are completely different, because the delayed symptoms may be more immunological, sore throat, light sensitivity. So go through with your patients to understand what the delayed symptoms look like versus the immediate. And I talked about it a little bit before, is that the physical, the cognitive, and the social emotional exertion will trigger different types of symptom presentations. And you can go through with your patients what those are and give them just a general rating, just so that you know how to track and how to tell your patients that for physical, you may be feeling more of your POTS symptoms. Is it an 8 or is it a 5? And then that's where you start judging and giving a little bit of control over how much they're able to do for that physical exertion. Where are you at in your symptom presentation? And does that activity match that level, or will it exceed the threshold immediately? So giving it a little bit of value, just so that they can start understanding how to reflect on their symptoms and then look at how to analyze the activity that they are choosing to perform. And this is where I go deeper in, and this is, I could spend a whole hour on this alone, but I just want to give you an example of how complicated analyzing activity is. But we do this naturally. We just need to understand that this is something that we need to do with our patients, and teach them. This is pacing, is figuring out how to analyze an activity for time. What time of day are you going to do this? You want to do a grooming activity. You want to take a bath or a shower. What time of day is it going to happen? How frequent? Is it going to be once a week? Is it going to be 3 minutes, or is it going to be a 5-minute, 10-minute bath in the tub? And then how much time do you need in between the rest and the activity? Physical, and this is a little bit of what PTs are especially good at doing, is looking at your physiological biofeedback. What's heart rate monitoring doing to understand how your body responds to exertion? Cognitive, it is what is the perception, the attention, what's the processing and the memory that goes for cognitive learning. And sometimes by speaking with speech therapists, they are really good at this. We can do this. We're trained in this, but this is obviously where speech therapists might have more tools, but it is not about practicing. It's not like somebody has had a stroke or has Alzheimer's or dementia. This is not about practicing these activities. This is giving them tools so that they are not working so hard, taking information in, processing that information, and kind of putting it out back into the public world through expression is a way that we can give them cues and supports, such as, using picture IDs or cheat sheets for communication. Those are some areas that I think speech therapists. Pardon? Oh, I'm sorry.
30 seconds.
Okay. And then we go through the sensory piece that OTs are really good at, looking at what the visual processing, all of the pieces of our sensory system, and the emotional is not just negative emotions, but also happiness and joy. That also is very exerting. And then our environment, our barometric pressures, our chemical smells, our world around us. And I will just briefly go through that. That's the tool bag that we often use as OTs. And then looking at rest, how rest is used as preemptive rest, and recuperative rest after the fact, after the activity, how well we recover from rest. And I'm just going to, on my slides, going to give a basic case sample that you can look at, that I'll make available just to look at some of these details. And this is where I broke things down a little bit deeper into task analysis, looking at some of the modifications. So thank you very much.